Thanks. We're going to shift gears a little bit, and we're talking about some of these quality measures that you may be rated on that involves the patient's perspective. This disclosure won't is not a conflict for this talk. So basically, I'm going to talk about the fact that patients remain an untapped resource to measure quality outside of the concept of patient satisfaction. And what I'm going to talk about is measuring what matters to patients. I'm going to go through some of the alphabet soup around this with PROs, PROMs, and now PRO performance measures. I'm going to talk about using patient-reported outcomes for performance measurement and quality improvement, and really some of the caveats and challenges around that. I'm going to talk about, that should be the NHS, the experience with using PROMs for quality improvement in England, and actually a little bit of a way forward for how this could be done potentially. So if we go to our value equation, and I thought this would be something that had already came up, so you've probably seen this equation before, but if value is defined as outcomes divided by cost, and Michael Porter from the Harvard Business School talks, is a real guru on this area, makes a point that the outcomes we're talking about are outcomes that are supposed to be outcomes that matter to patients. And the cost that you're talking about is for the entire trajectory of care. So you're talking about the outcomes, if you're talking about a condition or a disease like obesity, surgery might be a super dramatic, costly episode of care, but it's not what you're talking about when you're really talking about value. And when you talk about the outcome of the treatment of a disease, at the end of the day, you're talking about survival, you're talking about functional status, and you're talking about quality of life. I'm going to talk a little bit about what those really mean. You're talking about sustainability of benefits, so if this is going to recur or come back. And you're talking about how annoying and difficult and complicated it was to get that care. So how are we doing in using outcomes, the endpoint, the result of care, to measure quality? Well, we're really at the beginning of this journey. And this isn't just about surgery. This is we heard about the National Quality Measures Clearinghouse. If you look at all of their measures in this clearinghouse, over 1,900 measures, almost always, so more than 93% of the time, quality is defined as compliance with process measures and not outcomes improvement. And in fact, only 7% are outcomes, and less than 2% are patient-reported outcomes. Okay, so why does that matter? Because patient-centered care is one of the 6 pillars of high-quality care, along with safety and efficiency and all those other things. And if we're going to provide patient-centered care, we need information about care processes and outcomes that are important to patients. So if we're going to give information about options of treatments, surgical approaches, medical approaches, we need to be able to provide that care so that we can pick so we and the patients can pick the best option. This requires, in order to do this, we need the right tools to do this. We need tools to measure the impact of disease and the different treatments on different aspects of a patient's life. And this is meant to focus on outcomes that patients, families, and caregivers value, not only satisfaction. So when we talk about measuring what matters, and we talk about quality of life, this is a very complicated construct. So up here is a model, Wilson and Cleary model. This is a pivotal model of the determinants of health-related quality of life and quality of life that they published over 20 years ago in JAMA. And basically, this is a hierarchical model of the determinants of quality of life, and it's meant to point out where implementation might have an impact. Basically, this is a biopsychosocial model. So it says that biologic and physiologic variables have an impact on symptoms, which then have an impact on functional status, which have an impact on health perception, and ultimately on quality of life. So when you're talking about quality of life, you're talking about something that's a very, very high level thing. And in fact, there are many non-medical factors that impact on quality of life. And in fact, all of these different domains are also impacted by characteristics of the individual and the environment that we have no ability in healthcare to influence. So when you talk about picking a patient-reported outcome measure to measure quality, you have to be a little bit aware when you say quality of life that sometimes may not be directly influenced by some of the things that we do. So when we talk about quality measurement, we're supposed to be something that we can have is amenable to change if we change our practice. These are the domains that are patient-reported outcomes, which some of them can only be reported by patients. Some of them could be reported by observers, but some of these can only be reported by patients. And that's called a PRO, or patient-reported outcome. So that's PRO, patient-reported outcome. Patient-reported outcome measure, or PROM, are the tools we use to assess patient-reported health status. So these are instruments, scales, or single-item measures. So a single-item measure would be something like, okay, mark between 0 and 100 your overall health. And they provide a score or series of scores. And they can be generic. So examples of this would be SF36 or EQ5D or PROMIS. PROMIS is a little bit unique, so that's a bit of a hybrid, as I'll get to that in a second. These can be used across different populations, so you can compare the health of different populations using these generic measures. Or they can be disease-specific, so designed to measure symptoms in a specific condition, so you can't use them to compare, but often these are going to be more sensitive to change. They're going to be more sensitive to differences in treatment, whereas when you're measuring generically and quality of life, it may or may not be sensitive to small differences. So how are we doing in surgery in outcomes reporting? I mean, people have been talking about the importance of patient-reported outcomes for many, many years. And in surgery, if you look at, this is basically a scoping review. It took all clinical research papers published in some of our higher impact journals, and it classified them according to the Wilson and Cleary model. And you can see that still this is clinical research, so over 90% of the papers reported these biologic and physiologic variables, but only 36% reported symptoms. Only 39% had any patient-reported outcomes in them. And so only 13% had functional status, and only 10% had health-related quality of life. And this didn't change over the time that was looked at. What's also striking is we don't really know what we're doing here. So we have 15% of the papers that reported quality of life and used 46 different instruments to report that construct. And it's important that we kind of get a hold on what are the most important outcomes, what's the core outcome set for the different diseases that we treat. So patient-reported outcome measures can be used basically in three ways. So the way what they were developed to be used for was comparative effectiveness research. So basically to provide the patient perspective in clinical trials and for drug approval. But they can be used in two other ways, maybe other ways, but two other ways that I've thought of on this slide. So one was for clinical care. So can we use them, do we use them to guide clinical care decisions? So diagnosis or screening, treatment planning. So that would look like I give a patient a questionnaire, and depending on how a person answers, will determine if they're best suited for one kind of therapy or another, or response to treatment. We use that in treating patients with achalasia, for example, using symptom scores like Eckart's score and seeing their response to different treatments and if you use these clinically over time, you start to get a sense of what the scores mean and what is normal and what is not normal. And thirdly, what I want to focus on a little bit more is to assess quality, because this is a session about quality and this is where it gets a little bit tricky. So the idea of using PROMs to assess quality is to compare providers or organizations based on aggregate of patient-reported outcomes. So what does that look like basically? So if we have our PRO, that's about symptoms for patients. So if you take an example of a patient with achalasia, that would be symptoms that are related, that we see in patients with achalasia, dysphagia, chest pain, regurgitation. The PROM is the instrument that we would use to measure these patient-reported outcomes. So an example is an Eckhart score, where you have a series of symptoms and they're graded, and you get a score at the end from 0 to 12. But how that could be used as a PRO-based performance measure would be that there would be a benchmark, and you would say that patients after treatment for achalasia should have a score less than 3, and you would aggregate all the data, and you would look at the proportion of patients who met that benchmark. So that would be how you would use a PRO for performance measurement. So there's a lot of appeal for this. We've already heard a little bit about this. So we've heard a little bit that death and severe complications are relatively rare, and in some diseases, like Dr. Morton said, they've done really well at lowering this. But death and severe complications are not really measures of effectiveness, they're measures of safety, which is important, but it's pretty rare to die after an elective inguinal hernia repair, thankfully. And many, if not most, of the procedures we do are done to improve quality of life. And Dr. Dimmock had a very nice paper about this, I think it's more than 10 years ago, trying to decide which are the best outcomes, the structures, processes, or outcomes to use to define quality. And there was a quadrant there, I think it was the left upper quadrant, that said, patient-reported outcomes or patient-centered outcomes are very appropriate to use to measure quality. The other thing that's nice is that for complications, thankfully, they're rare, so only a few people contribute to your quality assessment, whereas with patient-reported outcomes, everyone contributes, and you get continuous variables instead of dichotomous variables. So there's a lot of appeal of this. But there's also a lot of uncertainty in using patient-reported outcomes for performance measurement. So fact is that most of us don't use these in clinical practice. Does anybody use patient-reported outcomes to make treatment decisions in this audience? So 1, 2. So it's rare. It doesn't mean, you can use it and it can be very useful, but most people don't use them. So we don't have a good handle on what the scores mean. We don't have a good handle on what the norms are. And we don't know what, in many of these cases for the diseases that we treat, what are the minimal important differences. We don't have core outcome sets for most diseases that we treat. So we don't really know which ones to use. We don't know how to collect the data. How do we get patients to fill out questionnaires? Language issues, cultural issues, literacy issues. How do we aggregate the data? So is it a percent? Is it a benchmark? Is it an average? And how to do the risk adjustment. So these are some of the uncertainties. But although there's a lot of uncertainty, that hasn't stopped some jurisdictions from forging ahead anyways. And this is a great story about how this can be used. So if you are in England and you work in the NHS, is there anyone here who works in the NHS? Okay, so basically since April 2009, all patients undergoing hip replacement, knee replacement, groin hernia surgery, and varicose vein surgery that are funded by the NHS, which is the vast, vast majority, are invited to complete questionnaires pre-op and then between 3 and 6 months post-op, depending on the operation. And you can Google this. You go to National PROMS program in England, you Google this, and they'll bring you to this webpage. And on this webpage is public reporting of all of these patient-reported outcomes for all providers. And if you go, I took the one for hernia, and you click down on this picture, and what you get is a map of England, and you can do groin hernia or knee or hip arthroplasty or varicose vein. And the PROM they used for hernia was the EQ5D, which is a utility. You get a score between minus 0.11 and 1. That's what I mean by it's hard to get a handle on what these scores mean a little bit. But they're case mix adjusted, and then you can see then anyone who this is different hospitals basically. And white means it's as expected, and red means you're 3 standard deviations outside of the average. And so you can see here that there's a lot of white, and there's one red and a couple of blues, which is 2 standard deviations above average. So if you look at the proportion, this is now at the individual level, at consultant level, the surgeon level, with outcomes more than 3 standard deviations different. For joint arthroplasty, they also used a disease-specific outcome. But for hernia, they only had the old EQ5D. EQ5D has 5 questions. It has something about whether you can take care of your own washing yourself, so it's pretty low level of quality of life. It has something about pain, it's something about activities, it has something about anxiety. So it's very, very low level. So for the disease-specific outcomes, they actually, if you 3 standard deviations mean anything more than 0.1% would be a little bit higher than you'd expect by chance. So they actually had more outliers by using PROMs than they did by looking at death after arthroplasty. So they had about 23 surgeons worse than expected, and 14 worse than expected for knee. But if you look at hernia, they had 0 better than expected. They had 972 consultants who were as expected, and they had 2 worse than expected after all of that work. And this is a surprise. This is about hernia, right? If you anybody part of this Facebook group, that International Hernia Collaboration, this is a question, just a screenshot from the other day, to think that only 2 are outliers on either side. This was a question of how to fix a hernia in a patient who's had radiation. It's a pretty common thing that you see. There were 21 comments, and these were the potential different options that were passionately debated about this very simple and common condition. So the idea that there's absolutely no difference in pain, in recovery, in functioning, in recurrence, in seromas, and anything that's important after a hernia operation is a little bit hard to believe. So actually, if you adjust for case mix and you do some adjustment based on hospital, if you do that, hospital and surgeon, patient factors explain 99.9% of the variance in outcome when you used PROM for hernia using EQ5D. And the funny thing is that the conclusion of this paper, and you can tell it was not written by surgeon or for sure, was that this suggests there is little opportunity to reduce variation between consultants through quality improvement initiatives such as additional training. So I guess Dr. Dimmock would disagree with that, and I think everybody who would come to a meeting like SAGES or any other meeting, or watch a video or can participate in any kind of collaborative would find that a little bit surprising. Not that they don't have the numbers of people to see any variation in outcome, or that the EQ5D is not a good measure, but that actually everything's fine and there's nothing you can do about it. And the same idea about the burning house and whether you just measure it or whether you do something about it is that just feedback alone, of course, has minimal impact on behavior, and of course that's the same for anything. So just having your NISQIP data or just having the data and not reacting to it or doing anything isn't going to fix anything. So this showed that there was no change, but collecting all this data for all this time wasn't associated with any change in outcomes. There was very little inter-provider variation. It didn't pick it up. But there's definitely a way forward. It doesn't mean that patient-reported outcomes can't be used for performance measurement. And we heard about the NQF, and they have some very nice papers and information that delineate a way forward. And there are ways to use patient-reported outcomes for performance measurement. But we need to follow sort of a roadmap to have this give us information that's useful. So the measure has to be psychometrically sound. Just because it's EQ5D and it's validated for measuring quality of life, you have to see that it discriminates between in the disease that you're interested in. And it's just a box here that shows that psychometrically sound is very complicated, and it takes a long time to figure that out, and it has to be reliable and valid and have these sound measurement properties in the condition that you're looking at. So whether it was good in determining quality of life in asthma is fantastic, but that doesn't mean that it relates to outcomes in hernia very well. Has to be patient-centered. What that means is that you could use it for shared decision-making with the patient. So you could sit down with the EQ5D score and say, well, you're 0.6, and therefore you would be better to have a laparoscopic operation. That's the kind of thing, it has to be something you can use. meaningful, so it has to be measuring something that has meaning to patients after the procedure for the disease that you're interested in. But very important is that it has to be amenable to change. So if you change something in quality, it has to be responsive to that change. That's very important. It may be valid to measure quality of life, but maybe it's not responsive or something that you could change by changing something in the care process. And has to be implementable. So they sent out questionnaires in the NHS to everybody, and they got 75% of them back, but maybe that's not the same in every jurisdiction. So a summary is that patient-reported outcomes provide very important information about the results of care from the patient's perspective. And they're an increasingly important aspect of performance measurement. But not all patient-reported outcomes are going to be good performance measures. And I think the bottom line is just, we've heard this a lot by some incredible leaders in this area that have taken a quality problem and made it into something that surgeons can be invested in. And I think the message is the same, that we are important stakeholders, that if we're not involved in determining the core outcome sets with our patients, then I think that we will have things measured that have nothing to do with the quality of the interventions that we are able to provide. So thank you very much.